So tonight we've got 2 hours of CE, I understand. And I'm not going to talk for the whole 2 hours. I want to leave some time for question and answer. But this is a big topic tonight. And the topic is adjusting the faucet or opening the drain. Basically, what are the current and near future methods of treating glaucoma? So by the end of this presentation, besides having a really nice dinner, okay, you should be familiar with the currently available and soon to be available, we hope, methods of treating glaucoma and how they work. So you should be aware of them all and have a pretty good idea of the mechanism. Now, this brings up something that's rather interesting. In order to figure out how to treat it and to talk about mechanisms, we first have to discuss, well, what is glaucoma? Now, we all have an idea of what it is. Okay? It's got something to do with the optic nerve. It's a progressive optic neuropathy, and it involves cupping and typical visual field or retinal nerve fiber layer loss. Okay? Now, it's also got something to do with pressure. We know all of those things, but we're finding out that it's not so simple, right? So the idea that high pressure is glaucoma, that we have to lower it, we figured that out a while ago that it wasn't that simple, right? Normal tension glaucoma, patients with ocular hypertension, but not glaucoma. So clearly there's something else going on. And what we're discovering is that blood supply is important, oxidative damage may be important, okay? And there may be some other issues involved, such as inflammation. So a lot of the laboratory research that's being done is actually focusing on those 3 things, not pressure. But that's pretty far into the future. Nothing that is involving non-IOP lowering therapy is anywhere near clinical usefulness. So we pretty much have to view glaucoma as a problem of plumbing. Okay? So even though we know glaucoma is far more complex than flow issues, this is all we've got. This is what we have to work with. Right? And so given that, what tools do we have available to us? And just like a good plumber, if you don't have the right tools or you don't know how to use the right tools for the right job, you're not going to be able to fix the faucet. So we can think about fixing glaucoma or treating glaucoma as fixing a sink. So if you've got a backed up sink, what can you do? Well, you could potentially adjust the faucet. So if the water is flowing and the sink is overflowing, one thing you can do is simply turn off the faucet. But with glaucoma, of course, you don't want to turn off the faucet, because if you don't have any flow, then you end up with hypotony. And with hypotony, you can end up with maculopathy, ptysis, things that you generally don't want. Okay? So we can adjust the flow, but we can't turn it off. Well, the problem is that if the drain is stopped up, even turning down the flow might not be enough. So of course then we can look at fixing the drain. Right? And if we're going to fix the drain, we have to think about, in terms of glaucoma, the outflow pathways. And there are physiologic pathways, so the pathways that are used by everyone's eye that doesn't have glaucoma. And then there are the non-physiologic, so basically those that we create. Now, in terms of the physiologic pathways, there's the trabecular meshwork. And the trabecular meshwork we can think of as basically the drainage grate here, right? So that's the first level at which fluid can come into a resistance. Right? Behind the grate is Schlemm's canal. So this is the canal that encircles the angle, sitting just behind trabecular meshwork, as you all know. And this can be thought of roughly as the drain that the U drain or whatever, again, I'm not a plumber. I use the the metaphor here, but I don't know anything beyond that great when it comes to the sink of my house, all right? So, but Schlemm's canal, we know, is basically a tube, right? And there are ways that we can interact with Schlemm's canal. Then there's the collector channel system. The collector channel system is rather mysterious. We don't have a way of testing it at this point, but we know that it's really important in terms of drainage. If the collector channel system, which takes fluid from Schlemm's canal to the venous collector system, does not work, then many of the treatments I will be discussing today simply won't work. So, that brings us to the next one, which is the uveal scleral pathway, which is a pathway that was little known prior to the advent of prostaglandin analogs. Now, this pathway does not use the classical or the usual pathway of the trabecular meshwork, Schlemm's canal, and collector channel system. It actually goes through the uvea here. And we'll talk about that because it's a very interesting option to take advantage of. Now, in terms of the non-physiologic pathways, we can shunt fluid. So whenever we're using a non-physiologic pathway, we're essentially creating a shunt. So a pathway which wasn't there before. And the standard pathway that's been used surgically since 1968 was trabeculectomy. So essentially poking a hole in the eye and shunting fluid from the anterior chamber into the subconjunctival space and creating a bleb. Now, the other thing we can do now, and we'll get to this, is shunt fluid into what's called the supraciliary or suprachoroidal space, which is below the sclera. So we've got above the sclera and below the sclera options that are non-physiologic shunts. So what I'd like to do is review the currently available glaucoma treatments, because although you've been aware of many of them, there are a couple of FDA-approved treatments that are relatively new. And it's helpful to put them in perspective in relationship to what's been available in the past. So, in terms of the currently available medical treatments, because we're going to break these up into medical, laser, and surgical, although technically laser is surgery, it's not incisional. So most patients take more kindly to laser than they do incisional surgery. We can look at the FDA-approved eye drops and oral medications. And I'm not going to spend a lot of time on this, although I do want to give it its due. So in terms of the eye drops, what we've got available here in the US, beta blockers, selective alpha adrenergic agonist, carbonic anhydrase inhibitors, both drops and oral, as well as prostaglandin analogs, the cholinergic receptor agonists, so pilocarpine, and then the fixed combination agents, of which we've got 3. So in terms of the beta blockers, Tomoptic, Betaxolol, so go ahead there, and others. Pretty much all we use is Tomoptic for most of our patients, unless they've got some cardiovascular issues. These have been around for a very, very long time. We know they work well, and they work by turning down the faucet. Okay, so beta blockers suppress aqueous production. Okay, and they do that by inhibiting C-AMP, cyclic AMP. Now, again, we're not going to go into all of the scientific and laboratory bench work on all of this because it's a lot to take in. And if you want that, the papers are available. You can break out or dust off your old textbooks. But I just want to make sure we get through everything today, which is quite a bit. One other thing is, although you've got some paper there and some pens to take notes for pearls and whatnot, don't worry about getting all of this. My plan is at some point to make these slides available online, and when I do so, I will we'll send out a notice to everyone. All right. So in terms of the beta blockers, although they're cheap, widely available and tolerated by most people. There are some issues with them. They can cause ocular irritation topically, but more concerning is bradycardia, so low heart rate, arrhythmia, irregular heart rate, heart block, right, so they can just stop the heart, systemic hypotension, so low blood pressure, and even heart failure. Okay? And traditionally we've been told, well, you know, be careful about using these in your elderly patients because they might be more sensitive to the beta blockers. So, you know, think you've got somebody who's young and healthy, shouldn't be a problem. Okay? Be careful though. I once had a patient who was in his 40s, an athlete, stocky guy, gave him a timolol, told him beforehand, thankfully, that these were issues. He ended up in the emergency room the first night that he took a beta blocker because he was, although his heart rate was reasonable for an athlete in the 50s and 60s, when he took the beta blocker, because he started off so low, he dropped down below 40. So you do need to be careful about that. Basically, anyone who's not really healthy or really unhealthy should be okay. But if you've got an athlete or somebody who's elderly and in terms of their cardiovascular status not so strong, you should be worried. Now, there are also non-cardiac issues. Central nervous system depression, impotence. Okay, if you've got somebody who's taken the blue pill, probably not a great candidate for a beta blocker, right? And by blue pill, you all understand Viagra or its fellow agents. More importantly than that, it may mask signs of hypoglycemia. So if you've got diabetic patients who fluctuate a lot and occasionally have hypoglycemic episodes, you do not want to use a beta blocker. It can also exacerbate asthma. And you know, from the things that I've just mentioned, I think it's pretty clear to see it can also result in death. We don't see it very often, but it does happen. So, selective alpha adrenergic agonists is the next class I'm going to look at. And that's basically brimonidine. Brimonidine works by turning down the faucet. And the selective ones, such as brimonidine, also open the drain. So it's nice. This particular agent actually does both. Okay? But as we're aware, it causes ocular irritation. And more worrisome than ocular irritation is the follicular conjunctivitis. This can happen up to 15% of the time. And when it happens, it can be whopping, and you have no choice but to discontinue. Of interest is you can also see eyelid retraction, contact dermatitis, and occasionally, although we don't think of it that often, a headache. Other things, dry mouth, systemic hypotension. Okay, so it's not just the beta blockers, bradycardia, arrhythmia, death. It's unlikely, but we can see it. But with regard to these last three here, it's most worrisome in infants and small children. So the adrenergic agonist should not be used in infants and small children because of the risk of central nervous system depression and death. Now, interestingly, there are a couple of potential benefits of these selective alpha adrenergic agonists such as brimonidine. One is, if you've got somebody with a small ptosis of approximately 1 millimeter, brimonidine is a great medical way to treat a small ptosis. It'll lift the eyelid by about 1 millimeter. Also, in terms of normal tension glaucoma, there is evidence that between a beta blocker and an alpha adrenergic agonist, brimonidine, that even with the same amount of intraocular pressure lowering, patients do better with brimonidine. So in other words, their visual fields are more stable, less likely to get worse over time. The carbonic anhydrase inhibitors, the next class we'll talk about. So basically azopt, brinzolamide, and trusopt, dorzolamide. Okay. These work by turning down the faucet, decreasing aqueous production. Okay. So carbonic anhydrase is present in the ciliary epithelium. Now the problem is that you have to actually block about 90% of the enzyme in order to get the effect that you want. So the problem with these is that they don't actually work all that well. Of the drops we've talked about so far, they're the least likely to work. Fortunately, they don't have too many side effects. Irritation, that seems to be pretty common with anything that you're going to use. Punctate keratopathy, some blurred vision, and some bitter taste. As I was saying, 90% blocking has to occur to get an effect, 15% reduction in pressure, not that impressive. Now, importantly, carbonic anhydrase is also used by the corneal endothelium in order to pump fluid out of the cornea. So if you've got somebody with a corneal endothelial dysfunction, this may not be the best choice. Okay? Lower pressure, but might swell the cornea up a bit. Prostaglandin analogs, we're aware there's a whole bunch of them available now. They open the drain, but not through the regular drain. They open up the drain through the uveal scleral outflow. They work quite well, but they do have some local side effects that can be, depending on the patient, either desirable or bothersome. Conjunctival hyperemia, almost always bothersome. Iris color change, almost always bothersome. And it only happens in the pigmented areas. So if you've got somebody that has blue eyes and there's no pigment, they're going to stay blue. If you've got somebody that's got blue with brown spots, those spots are going to become more noticeable. Hazel eyes become more brown. If you've got somebody with a dark brown iris, it's not going to matter. Lash growth, most people appreciate that, although some of the prostaglandins do tend, at least under the slit lamp, to provide more of a spidery, unruly lash growth, which isn't always appreciated. And men don't always appreciate it. But the other thing we've been seeing recently is prostaglandin-associated periorbitopathy. That's a mouthful. Which is essentially a reduction of the tissue around the eye. Now, early on, again, it can be rather desirable, right? So you've got somebody with some excess bags under the eyes. You apply the prostaglandins. Things seem to tighten up a little bit. It's like they've had a little laser surgery tightening, or sometimes it even looks like they've had a lower lid bluff. That's great early on, but if it progresses too far, it can actually tighten the lid so much that it's difficult to obtain a pressure measurement using Goldman applanation tonometry. So this can actually get in the way of your ability to monitor glaucoma. Now, there's some other things. You can get intraocular inflammation. This is a bit controversial, but the prostaglandins are part of the inflammatory cascade. So it makes perfect sense that they are pro-inflammatory. And indeed, there's evidence that they can increase the risk of macular edema, at least in those patients who are already at risk for macular edema. Herpes virus reactivation can be an issue, so you should generally not use this particular drop to lower the pressure in somebody who has a history of herpes virus infection, at least of the eye. And then headaches. There have been reports of pretty severe nocturnal headaches. Speaking of headaches, the cholinergic receptors, pilocarpine. What's the one thing we all think about with pilocarpine is headache. Now, these are still around because they can still be quite useful in those of our patients with narrow angles, but they're also still worth being aware of, just in terms of general practice, because they do work pretty well. They open the drain through a different mechanism than the ones we've talked about. Essentially, they provide some tension on the posterior trabecular meshwork and allow increased outflow. Okay. But brow ache, poor night vision due to the meiosis, induced myopia, and then there are these other issues. Retinal detachment, more of an issue with high myopes. But of course, if you've got a retinal detachment and somebody who has a small pupil that you can't dilate, that's an issue, right? And then less likely, but something that was more commonly seen with the older agents in this class, and also when we were using this drop a lot more, cicatricial conjunctival pemphigoid, corneal endothelial toxicity, so it's not just the carbonic anhydrase inhibitors that can give you issues with the corneal endothelium, it's also pilocarpine, and then band keratopathy. Okay. Fortunately, we now have these fixed combination agents. We have 3 of them here in the US: COSOP, timolol plus dorzolamide, Comagan, which is timolol plus brimonidine, and Simbrinza, which is brimonidine plus brinzolamide. My current favorite is Simbrinza, simply because it doesn't have the timolol component. Now, the other thing to keep in mind here is that these agents, COSOP and Comagan, the 2 that are fixed combination agents which do have timolol in them, you're using these twice a day. Okay? It's a twice a day agent where you're using timolol twice a day, which really is best used once a day in the morning, because the nighttime dose doesn't really help you all that much in terms of the aqueous production, which drops at night anyway. But the other thing is, we now know that using beta blockers at night can potentially put patients at risk for what's called dipping, which is where their blood pressure drops by 10 points. Patients who dip are at a much, much higher risk of progression with their glaucoma. So why in the world would you want to use a drop that places a beta blocker in the eye that then moves systemically in most patients at night? Now, the other issue here is we're dosing these twice a day, COSOP and Comagan. Well, dorzolamide and brimonidine both work best 3 times a day. So the COSOP and Comagan I've almost entirely eliminated from my practice, because in my mind, these are just bad compromises, right? You're not getting the right dosing on the brimonidine and the dorzolamide, and you're getting too much timolol and potentially actually putting your patient at risk if they're a dipper. Now, if you're worried about dipping, you can get a 24-hour blood pressure monitoring. It's not that expensive. It's not that much of a hassle. Generally, you work with the internist. Most internists are happy to do it because it's information they'd like anyway. But for that reason, I've really moved to Simbrinza, recommending it 3 times a day. If patients don't get that middle of the day dose, I tell them don't feel guilty about it. Just try to do it. All right? We've all got more guilt than we need. So those are the drops. Oral medications, the carbonic anhydrase inhibitors, again, they turn down the faucet, but the oral ones are far more effective than the topical ones. So the oral ones, again, are acetazolamide and neptazane. Okay? The issues with the oral ones, though, is systemic side effects: transient myopia, frequent urination, lightheadedness, paresthesias, extremity tingling. These are all bothersome, but they're not horrible. What's horrible is potentially in your older patients dehydration leading to falls, malaise, weight loss, GI symptoms, hypokalemia. Okay, so we all say to our patients, eat bananas. Bananas actually aren't the best source of potassium. Much better would be pomegranates, which we now have in abundance here. And soon enough, bananas won't be available anyway, so you might as well start recommending pomegranates before bananas go extinct. Metabolic acidosis, kidney stones, aplastic anemia, and death. So this is why you don't see patients on Diamox chronically, at least not too many of them. So those are medical treatments. Let's move on to the surgical treatments. You're going to start with the FDA-approved surgical treatments. Laser and incisional is what's available here. In terms of the laser treatments, we've got iridotomy, iridoplasty, trabeculoplasty, and cyclodestructive procedures. Okay, iridotomy, not going to spend a lot of time on that. We poke a hole in the iris, allows fluid through and out the natural drainage system. Okay, iridoplasty is plasty. So instead of making a hole, you're basically shrinking the iris. This is used in plateau iris. And what you see here in this picture is, here's the iridotomy. Okay, when the iridotomy doesn't work in plateau iris, you then do an iridoplasty. So what you do is you make a whole bunch of little spots here that pull the iris away from the angle. Okay, but what I really want to talk about here is the open angle glaucoma treatments, because narrow angle is pretty straightforward. It's not that interesting. There's not that much going on right now. whereas with open-angle glaucoma, there's a lot. And we can split open-angle glaucoma surgery into categories: the non-invasive or the laser, the minimally invasive, which is the most exciting, and then the penetrating, which is the, for the most part, the older style of surgery. Okay. Now we can also think about glaucoma surgical treatments in terms of how they work. They can shunt, they can enhance, so they can shunt fluid out of the eye, they can enhance the natural outflow, or they can ablate. They can basically destroy tissues. So mostly when we're talking about destroying tissue, we're talking about destroying the ciliary body. So I like to think of this in terms of mnemonics as C. All right. So let's look at enhancing here. Laser trabeculoplasty. You can split this up into argon selective and micropulse. The argon laser trabeculoplasty, or ALT, has been around for a very, very long time. Quick aside of interest, I always love to hear the stories about how scientific discoveries are made. In the case of laser trabeculoplasty, this was actually an accident. Okay? They were studying monkeys when this laser treatment came about, and they thought, well, let's poke little holes in the trabecular meshwork so that fluid can get through the trabecular meshwork, which tends to be the primary location of restriction of flow, and shunt it directly into Schlemm's canal. So they did it, but the problem with the monkeys is that they scarred down. So then they thought, we can use this laser instead to create a monkey model of glaucoma. So instead of poking holes, we'll just use a lower energy. We'll shrink or scar down the trabecular meshwork, and now we'll have these monkeys that we can study glaucoma treatments on, because we will essentially have created glaucoma in these monkeys. Well, lo and behold, after the monkeys healed up from the initial inflammation, what happened? Their pressures went down. So that's how ALT was discovered. All right? So then it was used in humans to essentially create small micro burns in the trabecular meshwork, and the thinking was that in between the burns you stretched open the trabecular meshwork. Nobody really knows. Okay? It can only be used in open-angle glaucoma, performed in 1 or 2 sessions, may result in microscopic scars. You are actually coagulating tissue, and it may limit future surgical options, in particular some of the newer options that are becoming available. So for that reason, it's not the best choice. Selective laser trabeculoplasty is becoming more commonly recommended, primarily because it doesn't destroy tissue. And because it's now becoming affordable. When this first came out, it was $70,000 to buy the laser. Who other than glaucoma specialists are going to be able to do that? But lately, the laser cost has come down into the $20,000 to $40,000 range. This uses a Q-switch frequency doubled ND-YAG laser. Not that anybody needs to know that. It can be performed on its own or even after ALT. It's less traumatic because it doesn't coagulate tissue, less damage. It's quick and it's usually painless. And interestingly enough, it can be performed either using a gonio mirror, as with the ALT, or a recent study that was just published showed that you can actually do this transsclerally. So you can just sit the patient at the slit lamp, aim the beam at the limbus, and place 100 spots around the limbus, and it works. Perhaps not as well, we don't know, but it does work. All right, so there it is. There's a laser spot, and it's lasering. All right. Fascinating. All right, micropulse laser trabeculoplasty. This basically uses micropulses, so really, really, really short pulses. And the idea is if you separate the pulses into tiny little pulses followed by a little pause and then another little pulse and then a little pause, what happens is you get what's called thermal relaxation. So the tissue heats up and then cools off, and then heats up and cools off. And you do not get coagulative damage when you do this. Basically, this is a newer version of SLT. It's a cheaper version of SLT, seems to work as well as SLT, and so there's some benefits to having this. Cyclodestructive procedures, okay? Continuous wave cyclophotocoagulation. This is traditionally been reserved for those patients who have end-stage glaucoma, where there's no potential for vision. It's just a blind, painful eye, and you'd place these laser spots transsclerally. You'd destroy the ciliary body, and you'd lower the pressure. But you could also lower it too much. You could essentially destroy the aqueous production and end up with a hypotenuse or even tisical eye. So this was not really used for too many patients, but it did have its use. Then there's the ab interno, the newer version, the endocyclophotocoagulation, or ECP. And the most exciting, I think, is the newest iteration of this, the Micropulse Cyclophotocoagulation, or MP3. So the ab externo, which is from the outside of the eye, continuous wave cyclophotocoagulation, we just talked about that. It was pretty uncomfortable. No, it was downright painful. So you actually had to block the eye or put somebody under anesthesia. And then not only, this is the other thing, not only could you get hypotony, but there was even the possibility that you could get sympathetic ophthalmia from the severe inflammatory response. So you treat one eye and the other eye would go blind. Not ideal. So this is why we didn't see much of this, but because it did have its use, it stayed around for a while. And eventually people figured out how to use this technology in a safer way that was still effective. And so endocyclophotocoagulation was developed. This can be used for mild to moderate glaucoma. It has to be done at the time of or after cataract surgery. And it's a relatively low-risk glaucoma. But it's also, relatively modest in its effect. And it does, as with anything you do with the iris or the ciliary body, it's going to result in some inflammation. All right. So here is an animation of the ECP. A viscoelastic is placed in the eye. A probe is then inserted, and the individual ciliary body processes are then lasered. And the trick is to shrink them. You have to shrink them enough that the epithelium stops producing aqueous, but you don't want to actually pop them. And what happens is you see them shrink, and if you go beyond the shrinking, they pop like popcorn. And unfortunately, that pop is so incredibly pro-inflammatory that this procedure is very much surgeon dependent. So if the surgeon understands the nuances of the procedure, you can get a nice effect without too much inflammation. If they've got a heavy hand or a heavy foot, as the case may be, it can actually result in a lot of inflammation. So the micropulse cyclophotocoagulation, this is, I think, as I said, one of the most exciting laser treatments that's available. This uses, as we talked about before, micropulses. So you've got tiny little pulses followed by a pause, allowing for the thermal relaxation. So this was thought of as a gentler form of cyclophotocoagulation. Nobody really knew how it worked. I mean, if you're not destroying the ciliary body process, how in the world are you getting a reduction in aqueous? Well, it turns out you're not. It doesn't work by reducing aqueous. It works by pulling on the posterior trabecular meshwork and essentially enhancing outflow, just like pilocarpine. Nice thing about this is, although it is uncomfortable and you still have to either block or put somebody under a quick 5 minutes of IV sedation, it's generally comfortable afterwards, very low risk, and works well, as we'll see in a moment. So this is the slow application. The laser's chopped into micropulses. The early studies looked at patients who, just like with transscleral continuous wave cyclophotocoagulation, were kind of end-stage patients. You can see these are patients with pressures in the 40s, and they come down in the mid-20s, right? Since that time, they've also studied patients who have more reasonable pressures, and the studies seem to indicate that they do about as well in terms of the percent reduction. And this is the procedure. It's an external procedure. There's no incision. It does not have to be done under sterile conditions. Essentially, you make about 9 passes superiorly, 9 passes inferiorly of this laser. And it's not technically challenging, although it can be somewhat challenging in patients who have small palpebral fissures, because if you don't get the laser posterior enough, you can end up with a change in the pupil size and potential inflammation. So, and that's probably the reason why pupil dilation is relatively common. Okay. Incisional surgery. Okay, so these are what we can basically split into penetrating, the more traditional ones, and the lower risk surgeries, which are called minimally invasive glaucoma surgeries or micro-invasive glaucoma surgeries, basically MIGS. Okay, and we'll go over how well MIGS go in a second, because you may have heard the tongue-in-cheek term MEGS, M-E-G-S, for minimally effective glaucoma surgery. And we'll see whether or not that's the case. Traditional penetrating surgeries, trabeculectomy and tubes. We all know about trabeculectomy. You create a fistula, so a shunt. Creates a bleb. The issues are bleb failure, lifetime risk of infection, and lifestyle limitation. You can't wear contact lenses in general. You can't go snorkeling or scuba diving, things like that. For our active baby boomer patients, this can be an issue. There's also other issues. You can have cystic blebs resulting in ocular surface disease. You can have scarred blebs, which is quite, it's in 5 years after trabeculectomy, you're more likely to have a cataract from the trabeculectomy than you are to have a working bleb. Okay. They've been around since 1968, and they've really not changed much in that time. So I think that we can all agree it's time to move on. And we're going to be talking about the potential methods by which we can move on. Traditional penetrating surgeries also include the glaucoma drainage devices. Essentially, there are two that are commonly used here in the U.S. The non-valved, which is the Barvelt, versus the valved, which is the Ahmed. And these have a number of issues along with that are shared, as well as somewhat unique from trabeculectomy. And in the case of the trabeculectomy and glaucoma drainage devices, the main risks are pressure elevation and hypotony, so both extremes there. Okay. In the case of the glaucoma drainage devices, you put an implant on the surface of the eye underneath the conjunctiva. So not surprisingly, the implant can sometimes move. You can get into trouble with that. You can get an infection. If you get an infection on an implant, whether it's an implant, in the eye or anywhere else, that's a big issue. You generally have to remove the implant. It's very hard to eliminate an infection on any non-biologic tissue. Scarring can cause double vision. Okay. And then there are other things. The implant itself, the tube, can erode. And with glaucoma drainage devices as well as trabeculectomy, if you end up with a sudden drop in pressure, you can end up with a suprachoroidal hemorrhage, so a bleed in the back of the eye that can lead to a total loss of vision, or at least put you at great risk of that. Okay, so essentially after incisional glaucoma surgery, that's the only time I will ever tell my patients that not only can they use a laxative or stool softener, but I want them to. Okay, because I want them to avoid any Valsalva maneuver, anything that could cause an increase in venous pressure, resulting in backflow into a hypotenuse eye. So given those risks, and given the fact that with glaucoma, we've got patients that generally can see, and we're trying to keep them from losing vision, I don't like offering surgical treatments that have a high risk of loss of vision. So this is where the newer, lower risk surgeries are really exciting. The question is, are the lower risk surgeries as effective as the higher risk, older penetrating surgeries? So we're going to look at to the ab externo, so from the outside, and the ab interno. Now, of the ab external, the main one is canaloplasty. This is essentially a modification of a surgery that's very commonly done in Europe, which is called deep sclerectomy, or viscocanalostomy is another version of that. And they use it in Europe because it's safer than trabeculectomy. Okay? Well, in the case of whether we're talking viscocanalostomy or canaloplasty, these are non-penetrating, so you're not actually creating a fistula from the anterior chamber into the subconjunctival space. So there's no hole, no bleb, but they work well. So you do lower the pressure, you have fewer drops in general, they're safer than traditional surgeries, and this is key for our patients who like to be active. You generally do not have to adjust your lifestyle, okay? And so showing you what canaloplasty looks like here. So you do, and this is just going to go through, the normal pathway of aqueous being produced by the ciliary epithelium, going out through the trabecular meshwork. But in the case of glaucoma patients, there's a blockage in either the trabecular meshwork or the Schlemm's canal. So with canaloplasty, you do create a partial thickness scleral flap. So it's not a full thickness scleral flap, it's a partial thickness. And a catheter, the world's smallest catheter, it's an incredible little 250 micrometer diameter catheter, is threaded through the canal, which is pretty neat to see. Once it's through, you tie a suture to it and pull the suture back through the canal. Okay? Now, why would you do that? The idea is, as you're pulling it back through the canal, you're actually injecting viscoelastic to dilate the canal. So it's kind of like angioplasty for the eye. Now, once you've pulled the suture back through, you tie it to tighten the inner wall of the canal, kind of like you'd tie a hoodie to bring it down. And you can see that pulling down on the inner wall. Now, what happens is you dilate the canal and you stent it open. So you get better flow into the Schlemm's canal and then out through the collector channel systems. Aha, but you have to have an open collector channel system, which there's unfortunately no way to detect beforehand. And this is going to be a theme through the rest of this talk. So how does it work? Well, it turns out it works pretty well. Okay, in one study that looked at the two surgeries, trabeculectomy versus canaloplasty, there was not a significant difference between the final pressures. 13.4 with trabeculectomy, and this was 1 year out, versus 13.4 with canaloplasty, correct myself, versus 12.3 with trabeculectomy and mitomycin C. So yes, trabeculectomy had a tendency to be lower, but it wasn't a statistically significant difference. What was different, importantly, is the risks. Okay, patients had better vision with canaloplasty. They had lower risk of hypotony. They had no issues with blebs. I could go on. Anyway, the 3-year results are quite good in terms of the reduction. So with canaloplasty only, there was 34% mean IOP reduction from baseline and a 53% reduction in drop use. So not only did the pressure drop, but the number of drops that were required to keep that pressure dropped as well. If you combine canaloplasty with phacoemulsification, so cataract surgery, it gets even better. 42% mean intraocular pressure reduction, 81% mean reduction in drops, and almost 90%, 88% of patients were drop-free 3 years after surgery, okay, without the risks of trabeculectomy. So this is a really, really exciting procedure. The doctor who developed canaloplasty, Dr. Robert Stegman, in South Africa, an absolute genius. I think this quote pretty much sums it up. It's vital to find a safer, more predictable operation with preferably no complications at all. And he felt that canaloplasty is the closest that he's ever come to that. And that's another point that I didn't make earlier. With trabeculectomy and glaucoma drainage devices, there's no coupling between surgeon skill and the outcome. Okay, you speak to experienced glaucoma surgeons, they will tell you, I will finish what I think is a perfect trabeculectomy and have no idea how this patient's going to do, because it's so dependent upon the body's healing response. And that's not the case with canaloplasty. So moving on to the minimally invasive glaucoma surgeries, which is really an exciting area right now. But the question is, are they also minimally effective? So the ones we're going to go over are the ones that are FDA approved. Ab interno canaloplasty, so this is canaloplasty from the inside of the eye, trabeculotomy, eye stent, CyPass, Zen gel stent, and cataract surgery. You may say, well, why is cataract surgery up there? Well, we'll get to that. So, interestingly enough, with the ab externo canaloplasty coming from the outside, they separated the results into those that had the stent and those that didn't have the stent. And what they saw was that although they generally did better with the stent, even if you couldn't get the stent in, the pressure still dropped. And you can see in this here 3-year results of those with ab externo canaloplasty but without the suture, the average pressure dropped from 25.2 millimeters mercury to 16.2. That's a pretty decent reduction. And the mean number of medications from 2.1 to 1.1, so by 1 medication on average. Right? So Dr. Mark Gallardo in El Paso, Texas thought, well, this is interesting. Well, is there a way that we could do this from the inside of the eye without making the incision from the outside of the eye, which would make it much less complex of a surgery and also a much faster surgery? Okay. And it turns out you can. And the neat thing about it is that by doing this, you treat the trabecular meshwork because you create an opening in the trabecular meshwork. You open Schlemm's canal. You potentially dilate the collector channels. You get better aqueous outflow. And there's no permanent stent or implant. And that's a key point of the ab interno canaloplasty. No permanent stent or implant. Okay. And what we'll do here is I'm going to take us through this here. So essentially, this is after cataract surgery. All right. So what's going to be done is you can see over here that here's the catheter is being inserted into the anterior chamber, and it's basically being rested against the angle here. Okay, then what happens is a gonio lens is placed on the eye. And here again, you can see that the catheter is resting there. So you're looking at the angle of the eye. And either a blade or a cystotome is used to actually pierce the trabecular meshwork, opening up into Schlemm's canal, which often results in a little blood reflux. So you can see a little blood there. Okay. And then this is what is so cool about this procedure. Microforceps are used to thread this catheter through. And so you can see the tip of the catheter is a blinking red catheter, and you're going to see it coming around here in a moment. So he's threading it around the Schlemm's canal. So he'll thread it all the way around. And then place another instrument in the eye to essentially hold the catheter up against the angle, and he pulls it back through. As it's being pulled back through, viscoelastic is being injected into the canal, dilating the canal. All right? So, how does it work? Well, the initial studies looking 1 year out basically show there's two. One was by Dr. Kiami, showed a reduction of from 19.5 to 13.9, with a reduction of average medications from 2 to 0. Dr. Gallardo showed a reduction of 18.6 millimeters mercury to 12.9. You get 12.9. I mean, that is in the range of what the trabeculectomy studies are showing, right? And mean reduction from 2 medications to 1. And if you actually combine the studies, mean IOP from 19 to 13.3, 2 meds to 1. So, these are very impressive results for a very safe and very fast surgery. What else can we do? Well, one thing we can do is dilate the canal. The other thing we can do is say, well, if the trabecular meshwork is the primary area of restriction, why don't we just rip it out or tear it open, right? And so we can do that. It turns out that if you've had a patient who's had ab externo canaloplasty, and at some point the pressure is no longer controlled, if they've had this stent, so if they've had the suture placed in the canal, you can go in with microforceps or another instrument and pull the suture through. Pulling the suture through rips open the trabecular meshwork. That's called microinvasive suture trabeculotomy. And in a 2-year study, it showed a 45% reduction in intraocular pressure. So low-risk procedure. Basically, the main risk you have is hyphema, so some bleeding in the front of the eye as you open up the trabecular meshwork. That generally goes away on its own. There's very low risk with any of these angle procedures of cyclodialysis, which can result in hypotony. That's a pretty low risk. So, the nice thing about canaloplasty is that you can potentially get a double benefit. You can get the initial opening of the canal, and then if you need to, you can pull the suture through the trabecular meshwork. Now, there's also, if you've got somebody who has not had canaloplasty, you can perform what's called gonioscopy-assisted transluminal trabeculotomy. That's essentially taking that catheter that we saw before, but instead of just dilating the canal, you move the catheter, or some people will use a suture if you want to get really cheap and you don't want to use an instrument that's been designed for this. It can be done. It's a bit more challenging. But in any case, you move the suture around the canal, and then you take the two ends of the suture and you pull through, and you rip through the trabecular meshwork. And it also shows a pressure reduction around 40% at 2 years. You can get more sophisticated and a whole lot more expensive. Ab-internal trabeculotomy has been done using a device called a trabectome, right, which has to be done with or after cataract surgery. As with all of the trabeculotomies, they do limit the potential for future canal-based surgeries. But the biggest issue with trabectome is it's darn expensive. Okay, this is the instrument here, and it's a pretty cool looking instrument. It has a foot plate to protect the posterior wall of the canal, and essentially it's got these electrodes that produce a plasma, and then it sucks up the trabecular meshwork tissue as it opens up the canal there. So it's about a $50,000 instrument, and then they make you purchase each of the hand pieces. So it's not been that popular when you've got these other less expensive options. And one of the more interesting, less expensive options is the Cahook dual blade. Okay? Basically, it's like a poor man's trabectome. Okay? But instead of using a plasma blade, it's got this neat, I'll show you this really neat design of this blade. There we go. That allows you to safely remove the trabecular meshwork as kind of a strip, so it strips it off. Okay? And so here you can see the tip of the blade there, and it's got a foot plate, and then these two side blades. So you've got a sharp tip to get into the trabecular meshwork. And boy, don't I wish the trabecular meshwork looked that clear and easy to find. Angle-based surgery is technically challenging. There's a high learning curve, but once you've got it, it can be quite fast and really gentle in terms of the patient experience. So this is a video of the trabeculotomy using the Cahook dual blade, and you can see the blades in the angle. It's getting it in the trabecular meshwork. Now he's going to come around from the other way. And it's pretty neat. You actually end up with this little strip of trabecular meshwork that if you were interested in it for research or other purpose, you can actually take it and send it to pathology. So you can see there's a little strip on the edge of it. They'll actually remove that in a second. All right, so other angle-based surgeries. The first microinvasive surgical implant to be FDA approved is the eye stent for use with ocular hypertension, mild open-angle glaucoma, to be done with cataract surgery. And you can see it's a pretty neat little device. It's this snorkel that is meant to be implanted through the trabecular meshwork into the canal. Problem is that it limits future surgeries. If you do this, you can't do canaloplasty or other procedures that require access to that area of the canal. And it's damn expensive. I mean, this device is the smallest FDA-approved surgical implant ever. Okay? It's made of titanium, and per ounce, this is the most valuable, expensive thing you could ever purchase. Okay? I think that, you know, some rare man-made element that you have to create in the Hadron Collider may be more expensive than this, okay? But per ounce. But this is well reimbursed. It's the implant itself is $1,000, and that's about what the surgeon is paid for implanting one of these. So they've become quite popular. The question is, do they work? And here's a video from Ike Ahmed, who is just a truly expert surgeon, and has had the ability to be involved in a lot of these new surgical procedures, done a lot in terms of, you know, figuring out how best to do these things. And this is him performing the surgery. And as with all of his surgeries, it's just elegant to watch. You can see him implant this stent, and he makes everything look so easy. But one of the things about this particular video, which underscores the issue with the eye stent, is you're going to see in this video, he does not implant one, does not implant two, he implants 3 of these in the eye. Now, if you implant 3 of these in the eye, you should get an effect. But the problem here in the US, separate from Canada, is you're only going to get paid for 1. And at $1,000 each, good luck finding a surgery center that's going to eat the extra $2,000, or a patient who's going to be willing to pay for the extra $2,000. But you can see how this goes into the canal through the trabecular meshwork. And I just love watching his videos. I can't think of too many eye surgeons who don't. His work is so nice. Anyway, so his surgical technique, absolutely fantastic. How about the results of the eye stent? Do they match his surgical technique? No, they don't. Okay. The 1-year results of the eye stent. Okay. Cataract surgery alone is done. The pressure is reduced by the percentage of patients who achieve a pressure lower than 22 millimeters mercury, 50%. So half of the patients, just from cataract surgery alone, will achieve that pressure under 22 millimeters of mercury. How about if you put the eye stent in with cataract surgery? 72%. Okay? So yeah, you do get more, but the majority of the reduction there is from the cataract surgery. You say, okay, well, you know, that some of these drops can be pretty expensive, right? I mean, we've all got patients who are saying, doctor, that drop that you prescribed me, the Simbrenza, is $250 a month. Well, a year of Simbrenza, and you know, this is paid for itself. So maybe not so impressive when you're looking at the difference between cataract surgery alone and cataract surgery plus the eye stent, but taking a bigger picture, it can be a useful option. But 2 years after surgery, there's no statistically significant difference between those who had cataract surgery alone and those who had cataract surgery plus the eye stent. So it's easy to put in. It's currently paid for by insurance, but is it really going to give us a long-term benefit? Probably not. So what other options are there? Well, just recently, at the end of 2016, the FDA approved the CyPass microstent. Now this is exciting because this is using an outflow shunting method that has not been available to us before. Okay? Now this is also, like with the eye stent, only approved for those who are also having cataract surgery. Okay? But the nice thing about this is because it uses a separate outflow, it can be used even in patients who have had or may need to have other glaucoma surgeries. Okay, and sorry, I want to show you this video here. So this is showing the outflow pathway, showing essentially both the pathway through the trabecular meshwork as well as through the uveoscleral outflow. You can see that this is it's essentially a tube, right? But it's a tube that's designed in such a way that it can atraumatically sit in the supraciliary space, right? So you can see that right in the angle above the ciliary body. and shunt fluid into that space. And it's a very quick procedure. So basically, you make an incision just like you would with cataract surgery. You fill the eye with viscoelastic, and I'm not sure that we need to see all the details of this. And you have this injector. It's placed into the angle and simply inserted into the supraciliary space. And there it is. So the question, of course, is how well does it work? So if we look at 2-year results, and we do have 2-year results on this, they looked at patients whose diurnal curve was between, I think it was 8 millimeters of mercury or 6 millimeters of mercury. That's right, 6 millimeters of mercury and 18 millimeters of mercury. And 61.2% of patients with a CyPass maintained this range versus 43.5% with cataract surgery alone. So again, what you see here is that cataract surgery alone does have a beneficial effect in treating glaucoma. So more, however, experience this range of diurnal curve with combined cataract surgery and CyPass. If we look at the absolute pressure reduction, 7 millimeters of mercury with a CyPass versus 5.3 millimeters of mercury on average with cataract surgery really doesn't look that impressive, right? Less than 2 millimeters of mercury. But if you look at the percentage difference, it was 32%. And again, what we're going to find is that with all of these lower risk microinvasive surgeries, we don't necessarily have to think of just one. We could potentially think of building up on different surgeries using different outflow pathways in order to achieve a reduction that could potentially end up in the same range as trabeculectomy or glaucoma drainage devices, but without the vision-threatening complications. And if we look at the 2-year results in terms of the percentage of patients who achieved a non-medicated pressure of 20 millimeters of mercury or less, so 20 millimeters of mercury or less without drops, 72.5% of patients with a CyPass achieve this versus almost 60% with cataract surgery alone. Okay. In terms of adverse events, there really weren't that many. When you look at the comparison of the combined CyPass with cataract surgery versus cataract surgery alone, overall quite similar. So it seems to be a pretty safe device. Also approved at the end of 2016 by the FDA, the Zen 45 gel stent. This is a chemically treated gelatin tube. It's basically what it is. It's a tube, but it's been designed so that the aqueous flow through it is restricted in such a way that it reduces the risk of hypotony. So this is essentially an ab interno method of trabeculectomy. You're shunting the fluid into the subconjunctival space, so it still requires a bleb to achieve intraocular pressure lowering, and as such, it still has all of the potential complications, or most, if not all, that trabeculectomy would. The issue with this is that although it shares many of the complications with trabeculectomy, and although it's much faster and in some ways easier to do, it doesn't seem to do quite as well as trabeculectomy in terms of pressure reduction. So the average drop of 30% from 20.8 to 14.4 at one year, not quite as impressive as trabeculectomy. 3-year results looked pretty good. 40% reduction, 75% medication reduction. About 5% of participants needed to go on to additional surgery, which is pretty typical for glaucoma surgeries. But as I was saying earlier, you have these issues of short and long-term hypotony, potential for loss of vision. Okay, that's not insignificant, right? 6.2% long-term loss. So that's on par with really trabeculectomy. Cataract surgery. I'm not going to belabor this point. You've seen already from the studies I showed earlier that cataract surgery alone can be effective with glaucoma. So for many of our patients who are kind of doing pretty well with their glaucoma, we'd like the pressure to be a little bit lower. They may be having some progression. If they've got cataracts that are ready for surgery and they're not maxed out on medications, then cataract surgery alone for many of these patients is perfectly reasonable. The issue, though, is if they are maxed out on medications and you perform cataract surgery and they have a pressure spike, which is not uncommon among glaucoma patients who have cataract surgery, then what are you going to do? Then your only option is Diamox. So patients who are on max tolerated medical therapy and need cataract surgery, we will generally consider combining the cataract surgery with one of these MIGS procedures. But if they're not maxed out, it's perfectly reasonable to consider just cataract surgery alone in those who have mild to moderate glaucoma. So what's in the pipeline? Next generation. Medications and surgeries in the pipeline. Quickly, the medications that you're going to see, some of these are already available, say in Japan and elsewhere, but hopefully we'll see these in the US. There's essentially 3 new classes of medications. The Rho kinase, or the ROCK inhibitors, they open the drain by relaxing the trabecular meshwork. The norepinephrine transport inhibitors, or the NET medications, they turn down the faucet. There's one in FDA trials right now, which is a ROCK-NET, so it uses both of these. So just like the alpha-2 agonists, you could potentially get both a reduction in the flow as well as, or reduction in the production of fluid as well as an improvement in the outflow, so that's very exciting. The adenosine receptor agonists, they work by increasing the outflow through the trabecular meshwork. And then there's the modified prostaglandin analogs. Now these are basically a prostaglandin analog plus a nitric oxide. Okay, so they're generally, you can think of some of these as prodrugs. They enter the antechamber, they're split up into the prostaglandin and a nitric oxide. Nitric oxide relaxes the trabecular meshwork in Schlemm's canal, increasing outflow. But what's really exciting, and what I'm going to end on here, is the next generation of plumbing, the surgeries. Okay, the iStent Supra is basically the Glaukos version of the CyPass, and it's exciting, but we've seen the CyPass. This isn't that different. I'm sure there's some nuances, and one may end up working better than the other or have fewer complications. But what interests me is what follows, the Hydrus microstent. This is actually a way of stenting the canal. So we've seen with the ab interno canaloplasty how we could dilate the canal. But the problem is, you've dilated, that's nice. Angioplasty of the heart, remember, many times the vessels would scar back down. So then they started putting stents in the vessels in the heart. Well, the same thing we hope we'll be able to do with the Schlemm's canal. Dilate the canal and leave a stent. So in this case, it's a small little stent, only as long as an eyelash. It's done with cataract surgery. Seems quite promising. Another Ike Ahmed video, which is, again, fun to watch. But given the time, I think that we'll hold off unless somebody wants to see it after the talk. I'm willing to stay around and do some theater here. The other is the InFocus microshunt. It's not; these things are not yet FDA approved, but they're in trials, and they may be. The InFocus microshunt is essentially, it's an ab externo, unfortunately. It's essentially a controlled trabeculectomy. So instead of creating a flap and punching a hole, you're essentially placing this device that limits flow. So very much like the Zen gel stent, which you could do from inside the eye, this is similar, but requires that you come from the outside of the eye. Now, personally, now that the Zen gel stent has been approved, I can't imagine why anybody would want to take the trouble to use this, but it might have a following. We'll see. The Zen gel has the advantage of both being ab interno, so quick and easy to do, as well as the fact that it's already FDA approved, so it's kind of, first one to market. If I was an investor, I would not be investing in the InFocus, but I'm not. So this is the one I'm most excited about, And I think you'll see why. We've been talking about minimally invasive glaucoma surgery and the problem with it potentially being minimally effective, especially when you compare it to cataract surgery. So Dr. Stegman, who created canaloplasty, thought this is great stuff, but can we make it better? And so in terms of what we just talked about with the hydrus as a scaffold from the inside, he thought, well, can I create a scaffold that can be used with canaloplasty? So he created this tube-shaped scaffolding device that's placed in Schlemm's canal and can keep, and this is the key, the hydrus and these other scaffolds are very, very small, only a few clock hours. In the case of this device, it can keep up to half the canal open permanently. And this video, I think, is worth seeing. And this is by Dr. Matthias Grieshaber, who is an outstanding glaucoma surgeon overseas. And you can see this is actually, he's already done the canaloplasty. He's pulled the catheter back, and you saw the viscoelastic gel at the end of it. So he's dilated the canal. Now, here is this stent. You can see it's a pretty long stent. What he's going, the stent is on a, it's essentially a guide wire. So what he's going to do is he's going to thread this guide wire back through the dilated canal. And now you can see at the end of this guide wire is this stent. And he's going to place this stent, again, using the guide wire to help it move along. He's going to move this into the canal. Now this is such a long stent that he wouldn't be able to do this without the guide wire. And now he'll pull the guide wire out, holding on to the stent. And then once this is done, he'll then do the same thing on the other side and then close up as he would any canaloplasty. So is it successful? It certainly looks like it should be. Well, we now have 2-year results, and if we look at the success, and recall earlier I was talking about success rates with the different minimally invasive glaucoma surgeries in terms of the percentage of patients who had pressures at or below 20, 21. The problem with these studies is they all use kind of a different outcome. But if you recall those, compare that to this. For those who had a final intraocular pressure of less than or equal to 21 millimeters of mercury, there was a 98% success rate. Almost 100% of those who had this surgery had a final pressure of less than or equal to 21 millimeters of mercury. That is absolutely outstanding. And if you want to lower the threshold, make it more challenging, less than or equal to 18 millimeters of mercury, almost 90%, so 88%. And if you dropped it even further, less than or equal to 16 millimeters of mercury, you had an 86% success rate. Okay, that is unheard of for a procedure with the safety profile of canaloplasty. And the Stegman canal expander did not significantly increase the risk over and above what one would expect from canaloplasty. And here's the key slide I want to show you, because we've started out talking about medications and the fact that all of these medications have risks and side effects and issues that bother our patients. We moved into surgery, the penetrating surgeries that have been around for over 50 years, right, a half a century, with all of the risks, okay? And we said, well, the problem is nothing's as good as trabeculectomy. Okay? The holy grail is to get a safer procedure that is as effective as trabeculectomy. And if we look at the 2-year study results of the trabeculectomy versus tube study, which is one of the most commonly referenced studies looking at the outcome of trabeculectomy, and we compare that with the 2-year results of the canaloplasty with Stegman canal expander, let's take a look at this. Initial IOP in those two studies. The TVT studies, so again, trabeculectomy, 25.6. The canaloplasty, 26.8, so similar starting. Final IOP, 12.1 millimeters of mercury in the TVT for trabeculectomy, 13.3 for the Stegman canal expander with canaloplasty. 1 millimeter of difference. We can also look at percent reduction. 52.7 in the trabeculectomy, 50.4 with canaloplasty with stegman canal expander. Initial glaucoma medications, 3 in trabeculectomy, 2.8 in canaloplasty with stegman expander. So again, very, very similar. Final number of glaucoma medications, 0.8 with trabeculectomy and 0.2 with canaloplasty and the stegman expander. And if we look at the percent reduction of medication use, 73% with trabeculectomy, 93% with canaloplasty with a stegman. So it is at least, based on this comparison, one can feel pretty confident that this is not inferior, not significantly inferior to trabeculectomy, okay, in terms of pressure reduction. But in terms of safety profile and the limitations that one would have to place on the patient, there's no question that trabeculectomy is the loser here, and canaloplasty with stegman canal expander is the winner. Now, the only issue here is that unlike the other things I've shown you in the pipeline, the stegman canal expander is much further out. So the best we can get today with this is the canaloplasty alone. We don't yet have, and will probably not have for quite a few years, if ever, depending on the FDA and what they decide, have this. But I am so incredibly hopeful that we will get that, because I think that is the minimally invasive glaucoma surgery that is also maximally effective, right? So a lot of interesting stuff coming down the pipeline. Of course, what we get and what we can just kind of look overseas and wish we had is something that we won't know, and it's out of our control. But hopefully, I've at least introduced a couple of new things to those of you and refreshed your memory on some old things. And I'm going to open it up for, what was that there? I'm going to open it up for questions. And any questions that don't get answered today, this afternoon, please feel free to give me a call or an email. I've put that's my office number there and my email, but I'm also willing to give out my cell phone number to anybody who would like to call me personally. All right, thank you.
So thank you again, Dr. Richardson.
Very good.
So very, very good lecture. Thank you very much. We like to have this for you.
Oh, thank you.
Thank you. And are you going to take questions?
Yes, absolutely. So unless I've just exhausted everyone. But,
thank you all for coming out tonight. It was a wonderful lecture. And once again, thank you, Dr. Richardson.
Thank you.